Good day. Stroke syndromes are a long topic, but please bear with me. Stroke is generally defined as any disease process that interrupts blood flow to the brain. Injury is related to the loss of oxygen and glucose substrates necessary for high-energy phosphate production and the presence of mediators of secondary cellular injury. Subsequent factors such as edema and mass effect may exacerbate the initial insult. The vascular supply is divided into anterior and posterior circulations. Clinical findings in stroke are determined by the location of the lesions, but the degree of collateral circulation may cause variations in the specific clinical symptoms and their severity. Stroke results from two major mechanisms, ischemia and hemorrhage. Ischemic strokes account for 87% of all strokes and are categorized by cause, thrombotic, embolic, or hyperperfusion related. Hemorrhagic strokes are subdivided into intracerebral, accounting to 10% of all strokes, and non-traumatic subarachnoid hemorrhage, accounting for 3% of all strokes. The final common pathway for all of these mechanisms is altered neuronal perfusion. Neurons are exquisitely sensitive to changes in cerebral blood flow and die within minutes of complete cessation of perfusion, hence the current treatment emphasis on rapid reperfusion strategies. The early detection of stroke must begin with the general public. In general, stroke knowledge among laypersons remains suboptimal and has led to several educational initiatives to raise stroke awareness. Three of the more commonly used pre-hospital tools are the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen, and the Melbourne Ambulance Stroke Screen. Time is a critical component in the care of stroke patients. EMS personnel should quickly ascertain the time of onset of the patient's symptoms, giving particular attention to bystander accounts to clarify details because stroke patients may be poor historians. Family members and/or witnesses to the event should be urged to come to the ED as soon as possible to provide further medical information to the treating physician. Time at the scene should be limited. EMS personnel should rapidly stabilize the patient's condition and transport the patient to a facility capable of optimally managing acute stroke, being sure to notify the receiving facility of the patient's condition and estimated time of arrival. In some cases, it may be necessary to bypass closer but less capable facilities in order to increase the chances of the patient receiving the best possible care. The diagnosis of stroke in the ED rests on the bedrock of a focused, accurate history and physical examination. The clinical presentation of stroke can range from the obvious, facial droop, arm drift, abnormal speech, to the subtle, which includes generalized weakness, lightheadedness, vague sensory changes, and altered mental status. Women account for slightly more than half of new or recurrent strokes in the developed world, and modest gender differences exist in terms of presenting signs and symptoms. In general, women tend to report diffuse, non-traditional symptoms and are less likely to report traditional symptoms when compared to men, but evidence of these distinctions is limited. So, as mentioned earlier, the venous supply to the brain is divided into anterior and posterior circulations. Anterior circulation refers to the internal carotid system. Major arteries include the ophthalmic, which supplies the optic nerve and retina, the anterior cerebral, which supplies the frontal pole, anteromedial cerebral cortex, and anterior corpus callosum, and the middle cerebral, which supplies the frontoparietal lobe and the anterotemporal lobe. The posterior circulation is also known as the vertebral system. The major arteries are the vertebral, posterior inferior cerebellar, basilar, posterior cerebellar, posterior cerebral, and medial temporal lobe. For the vertebral artery, it supplies the brainstem. The posterior inferior cerebellar supplies the cerebellum. Basilar supplies the thalamus. Posterior cerebral supplies the auditory and vestibular structures, and the medial temporal lobe supplies the visual occipital cortex. The timing of symptom onset, the presence of associated symptoms, and the medical history may point toward a particular mechanism of stroke. For example, sudden onset of symptoms suggests an embolic or hemorrhagic stroke, whereas stuttering or waxing and waning deficit suggests a thrombotic or hypoperfusion-related stroke, which are all under the ischemic category. A history of Valsalva maneuver immediately preceding a thunderclap headache or sudden onset of symptoms suggests a ruptured cerebral aneurysm, whereas a recent history of neck trauma or manipulation suggests cervical artery dissection. Risk factors for vessel thrombus include hypertension, diabetes mellitus, and coronary atherosclerotic disease. In contrast, atrial fibrillation, valvular replacement, or recent myocardial infarction suggests embolism. Transient neurologic deficits occurring in the same vascular distribution suggest underlying vascular disease consistent with a thrombotic stroke, whereas transient deficits involving different vascular distributions suggest embolism. Although adjunctive history can be helpful in determining the type of stroke, exhaustive or unduly prolonged attempts to elicit non-essential history should not delay therapy. We accurately determine the time of symptom onset. Time of onset is frequently misreported as the time the patient is discovered with symptoms or the time of awakening if the symptoms were not noted upon awakening. For the purposes of thrombolysis, if a patient awakens with the symptoms of stroke, the time of onset is the last known time when the patient's condition was at baseline. Exclude as many stroke mimics as possible. After stroke mimics are excluded, if acute stroke is still the most likely diagnosis and the symptom onset is within the recommended time limits for thrombolytic therapy, elicit information pertaining to inclusion and exclusion criteria for thrombolytic therapy. When it comes to stroke classification, as mentioned earlier, you can divide stroke into ischemic and hemorrhagic stroke. Ischemic stroke is divided into thrombotic, embolic, and hypoperfusion, whereas hemorrhagic stroke is divided into intracerebral and non-traumatic subarachnoid. Thrombotic stroke's mechanism is through narrowing of a damaged vascular lumen by an in situ process, usually clot formation. Major causes include atherosclerosis, vasculitis, arterial dissection, polycythemia, hypercoagulable state, and infections such as human immunodeficiency virus infection, syphilis, trichinosis, tuberculosis, and aspergillosis. Symptoms often have a gradual onset and may wax and wane. It is a common cause of transient ischemic attack. Embolic strokes are due to obstruction of a normal vascular lumen by intravascular material from a remote source. Major causes include valvular vegetations, mural thrombi, paradoxical emboli, cardiac tumors or myxomas, arterial emboli from a proximal source, fat emboli, particulate emboli such as in intravenous drug use, and septic emboli. It's usually typically sudden in onset compared to thrombotic stroke, and it accounts for 20% of ischemic strokes. Hyperperfusion is due to a low blood flow state leading to hypoperfusion of the brain. It is often caused by cardiac failure resulting in systemic hypotension. It has a diffuse injury pattern in watershed regions, and symptoms may wax and wane with hemodynamic factors. For hemorrhagic stroke, intracerebral stroke is due to intraparenchymal hemorrhage from previously weakened arterioles. It may be caused by hypertension, amyloidosis, iatrogenic anticoagulation, vascular malformations, and cocaine use. Intracranial pressure rise and hypertension causes local neuronal damage. Secondary vasoconstriction mediated by blood breakdown products or neuronal mechanisms such as diastasis can cause remote perfusion changes. Risks include advanced age, a history of stroke, and tobacco or alcohol use. It is also more common in those of Asian or African descent. Non-traumatic subarachnoid hemorrhagic stroke is due to hemorrhage into the subarachnoid space. This may be due to berry aneurysm rupture or vascular malformation rupture. It may be preceded by a sentinel headache, which is also known as a warning leak. Airway, breathing, and circulation are top priorities. Next, the goals of examination are to confirm the diagnosis of stroke, exclude stroke mimics, and identify comorbidities. Fever should prompt an investigation for potential infection. CNS infections such as meningitis or encephalitis may mimic a stroke, or an infection such as aspiration pneumonia or a urinary tract infection may be a complication of the stroke. Look for meningismus, signs of emboli such as Janeway lesions and Osler nodes, and bleeding diathesis such as ecchymosis or petechiae. A fundoscopic examination may identify signs of papilledema, suggesting a mass lesion, cerebral vein thrombosis, or hypertensive crisis, or pre-retinal hemorrhage, which is consistent with subarachnoid hemorrhage. The pre-hospital stroke scales discussed earlier are the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen, and the Melbourne Ambulance Stroke Screen. So for the Cincinnati Pre-Hospital Stroke Scale, the factors that are included are facial droop, which is abnormal if one side of the face does not move as well as the other side. Arm drift, which is abnormal if one arm does not move or one arm drifts down compared with the other. Or speech, which is abnormal if it's slurred with inappropriate words or the patient is mute. If any of the three items that I mentioned are abnormal, the sensitivity is 66% and the specificity is 87% for acute stroke. For the Los Angeles Pre-Hospital Stroke Screen, if the answers to all items that I'm going to mention are yes or unknown, the sensitivity is 91% and the specificity is 97%. One is age greater than 45 years old. Two is no history of seizure disorder. Three is new onset of neurologic symptoms in the last 24 hours. Four is patient ambulatory at baseline prior to the event. Five is a blood glucose level of 60 to 400 milligrams per deciliter. And sixth is obvious asymmetry in any of the following examinations: facial smile or grimace, grip, and arm strength. The Melbourne Ambulance Stroke Screen requires that all answers to 1 to 4 are yes, plus at least one among the 5th to the 8th factor being present, with a sensitivity of 90% and a specificity of 74%. 1. Age of more than 45 years. 2. No history of seizure or epilepsy. 3. Not wheelchair bound or bedridden at baseline. 4. Blood glucose of 50 to 400 milligrams per deciliter. So as you notice, these are pretty similar to the Los Angeles Pre-Hospital Stroke Screen. Then, at least one of the following must be also present. 5 is a unilateral facial droop. 6 is unilateral hand grip weakness. 7 is unilateral arm drift. And 8 is abnormal speech. Selected stroke symptoms are divided into traditional symptoms and non-traditional symptoms. Traditional symptoms are more common in men, and non-traditional symptoms tend to be more common in women. So traditional symptoms are sudden numbness or weakness of the face, arm, or leg, especially unilaterally, sudden alteration in mental status, sudden aphasia, sudden memory deficit or spatial orientation or perception difficulties, sudden visual deficit or diplopia, sudden dizziness, gait disturbance or ataxia, or sudden severe headache with no known cause. Non-traditional symptoms include loss of consciousness or syncope, generalized weakness, shortness of breath, sudden pain in the face, chest, arms, or legs, seizure, falls or accidents, sudden hiccups, sudden nausea, sudden fatigue, sudden palpitations, and altered mental status. We look for findings suggestive of possible cardiac or vascular disease such as rales, an S3 gallop, or a carotid bruit. The NIHSS is the standard tool for documenting the severity of a stroke. The National Institutes of Health Stroke Scale is an 11 category with 15 items neurologic evaluation with a score range of 0 to 42 that is quick to use, yields reproducible results, has a high inter-rater reliability, and provides a score that correlates with infarct volume. A modified NIHSS, which omits the redundant and least reliable items, produces clinical results similar to those for the full NIHSS and is easier to use, with a score range of 0 to 31. An important caveat is that the NIHSS is weighted toward the detection of anterior circulation strokes as opposed to posterior circulation strokes. This is because common symptoms of posterior strokes, which are cranial nerve deficits and ataxia, receive fewer points, and ataxia is often scored as absent by raters if weakness is present. For example, one study found that the NIHSS score associated with the favorable outcome was less than 5 for posterior circulation strokes and less than 8 for anterior circulation strokes. In addition, the NIHSS has a bias toward detection of dominant hemisphere strokes. So when it comes to ischemic stroke syndromes, we begin with anterior cerebral artery infarction. Occlusion of the anterior cerebral artery is uncommon, but when unilateral occlusion occurs, it can cause contralateral sensory and motor symptoms in the lower extremity, with sparing of the hands and face. In addition, a left-sided lesion is typically associated with akinetic mutism and transcortical motor aphasia, with repetition ability retained, whereas right-sided infarction can result in confusion and motor hemi-neglect. Bilateral occlusion can cause a combination of the above symptoms, but was particularly associated with mutism, incontinence, and poor outcome in one small series. Middle cerebral artery infarction involves the middle cerebral artery, which is the vessel most commonly involved in stroke, with clinical findings that can be quite variable, depending on exactly where the lesion is located and which brain hemisphere is dominant. In right-handed patients and in up to 80% of left-handed patients, the left hemisphere is dominant. A middle cerebral artery stroke typically presents with hemiparesis, facial plegia, and sensory loss contralateral to the affected cortex. These deficits variably affect the face and upper extremity more than the lower extremity. If the dominant hemisphere is involved, aphasia, which may be receptive, expressive, or both, is often present. If the non-dominant hemisphere is involved, inattention, neglect, extension on double simultaneous simulation, dysarthria without aphasia, and constructional apraxia, which is difficulty in drawing complex two-dimensional or three-dimensional figures, may occur. A homonymous hemianopsia and gaze preference toward the right side of the infarct may also be seen, regardless of the size of the infarction. For posterior cerebral artery infarction, the classic symptoms and signs of posterior circulation strokes include ataxia, nystagmus, altered mental status, and vertigo, but the presentation can sometimes be rather subtle. Cross-neurologic deficits, such as ipsilateral cranial nerve deficits with contralateral motor weakness, may indicate a brainstem lesion. According to an analysis of a large stroke registry, symptoms of posterior cerebral artery involvement include unilateral limb weakness, dizziness, blurry vision, headache, and dysarthria. Common presenting signs include visual field loss, unilateral limb weakness, gait ataxia, unilateral limb ataxia, cranial nerve Savin signs, lethargy, and sensory deficits. Visual field loss, classically described as contralateral homonymous hemianopsia and unilateral cortical blindness, is thought to be specific for distal posterior circulation stroke because the visual centers of the brain are supplied by the posterior cerebral artery. Light touch and pinprick sensation deficits, loss of ability to read, also known as alexia, without agraphia, inability to name colors, recent memory loss, unilateral third nerve palsy, and hemibalismus have also been reported. Motor dysfunction, although common, is typically minimal, which can keep some patients from realizing that they have a stroke. Basilar artery occlusion, which corresponds to the middle posterior circulation, commonly presents with symptoms of unilateral limb weakness, dizziness, dysarthria, diplopia, and headache. The most common presenting signs are unilateral limb weakness, cranial nerve 7 signs, dysarthria, Babinski sign, and oculomotor signs. Dysphagia, nausea, or vomiting, dizziness, and Horner syndrome are positively correlated with basilar artery occlusion. Basilar artery occlusion can also rarely cause locked-in syndrome, which occurs with bilateral pyramidal tract lesions in the ventral pons and is characterized by complete muscle paralysis except for upward gaze and blinking. Basilar artery occlusions have a high risk of death and poor outcomes. Vertebro-basilar infarction involves the proximal posterior circulation. Patients with vertebro-basilar infarction most commonly present with symptoms of dizziness, nausea or vomiting, headache, dysphagia, unilateral limb weakness, and unilateral cranial nerve 5 symptoms. Common presenting signs include unilateral limb ataxia, nystagmus, gait ataxia, cranial nerve 5 signs, limb sensory deficit, and Horner syndrome. Patients with cerebellar infarction can present with very nonspecific symptoms and frequently present with dizziness, with or without vertigo, nausea and vomiting, gait instability, headache, limb ataxia, dysarthria, nystagmus, and cranial nerve abnormalities. Mental status may vary from alert to comatose. Because CT is inadequately sensitive for posterior fossa lesions, obtain a diffusion-weighted MRI when this diagnosis is suspected. A CT angiogram or magnetic resonance angiogram is useful to characterize any vascular lesion once a diagnosis is made. The clinical presentation and course of cerebellar infarction can be frustratingly difficult to predict, but the clinician must remain vigilant to the possibility of rapid deterioration secondary to increased brainstem pressure caused by cerebellar edema. Therefore, Extremely close serial examinations, especially looking for gaze palsy and altered mental status, and prompt neurologic and neurosurgical bedside consultations are needed. Obtain early neurosurgical consultation for patients with cerebellar infarction. Cerebellar edema can lead to rapid deterioration with herniation, and consultation is required to determine the need for emergency posterior fossa decompression in these patients. Acute obstructing hydrocephalus requires treatment of elevated intracranial pressure and emergent surgical decompression. Lacunar infarcts are pure motor or sensory deficits caused by infarction of small penetrating arteries and are commonly associated with chronic hypertension and increasing age. The presentation is variable based on the location and size of the lesions. The prognosis is generally considered more favorable than for other stroke syndromes. For carotid and vertebral artery dissection, they are both uncommon, but they are an important cause of stroke, especially in young and middle-aged patients. A history of neck trauma in the days to weeks prior to presentation is a prominent risk factor. The trauma is usually minor, such as manipulative therapy of the neck or sport-related trauma. Other risk factors include connective tissue disease, a history of migraine, large vessel arteriopathies, and hypertension. The typical first symptom of patients with carotid or vertebral artery dissection is unilateral headache, neck pain, or face pain, which can precede other symptoms by hours to days, with a median of 4 days. New onset headache or neck pain of unclear etiology is such an important symptom that imaging of the neck vessels is recommended by some as part of initial evaluation. Symptoms may be transient or persistent. The median time between an initial presentation of neck pain and the development of other neurologic symptoms is 14 days. But if headache is the first symptom, other neurologic symptoms follow within a median time of 15 hours. For carotid artery dissection, the headache is most commonly in the frontotemporal region, and due to its variable quality and severity, may mimic subarachnoid hemorrhage with a thunderclap headache, temporal arteritis, or pre-existing migraine. A partial Horner's syndrome, which is meiosis and ptosis, has traditionally been linked to carotid artery dissection, but only occurs in about 25% of patients and is a sign accompanying other disorders besides stroke. Associated cranial nerve palsies have been reported in 12% of carotid artery dissections. Carotid dissection can progress to cause cerebral ischemia or rarely retinal infarction. Vertebral artery dissection commonly presents with neck pain and headache, both of which can be unilateral or bilateral. The headache is typically occipital, but can rarely present with pain on an entire side of the head or in the frontal region. Other symptoms and signs may include unilateral facial paresthesia, dizziness, vertigo, nausea or emesis, diplopia, and other visual disturbances, ataxia, limb weakness, numbness, dysarthria, and hearing loss. Cervical radiculopathy, which is typically a peripheral motor deficit at the C5 level, is a rare presentation and can also involve multiple levels and sensory findings. Untreated vertebral artery dissection may result in infarction in regions of the brain supplied by the posterior circulation. MRI or magnetic resonance angiography and CT or CT angiography are the diagnostic modalities of choice for suspected carotid, vertebral, or basilar artery dissection. Choice of study is usually determined by consultation with the neurologist and radiologist. Color-duplex ultrasound may not detect important vascular lesions. In the absence of contraindications, carotid and vertebral artery dissection has been traditionally treated with intravenous heparin, followed by warfarin, to maintain an INR of 2.0 to 3.0. This treatment has persisted despite the absence to date of published high-quality randomized controlled trials comparing anticoagulation with other potentially more effective treatment modalities. In 2012, the non-randomized arm of the cervical artery dissection and stroke study was published along with a meta-analysis of previous trials. These preliminary results showed no difference between anticoagulation and antiplatelet therapy in terms of prevention of stroke after cervical artery dissection. Non-randomized data regarding endovascular approaches to cervical artery dissection have been published, but no randomized controlled trial has been published yet. Therefore, pending the availability of new randomized controlled trial data, administer either anticoagulant or antiplatelet therapy in the emergency room in conjunction with appropriate specialist consultation. Stroke mimics include seizures or post-ictal paralysis, also known as Todd's paralysis. It is distinguished because transient paralysis follows a seizure, which typically disappears quickly, but it could also be confused with a transient ischemic attack. Seizures can also be secondary to a cerebrovascular accident. Syncope does not have any persistent or associated neurologic symptoms. Meningitis or encephalitis presents with fever. An immunocompromised state may be present, meningismus, and it is also detectable on lumbar puncture. Complicated migraine can be distinguished through a history of similar episodes, a preceding aura, and headache. A brain neoplasm or abscess may be distinguished through focal neurologic findings, signs of infection, and it is also detectable by imaging. Epidural or subdural hematoma can be distinguished through a history of trauma, alcoholism, anticoagulant use, bleeding disorders, and can also be detected through imaging. Subarachnoid hemorrhage leads to a sudden onset of severe headache. Although subarachnoid hemorrhage is a type of stroke, it has special considerations in terms of diagnosis and management, which is why it is listed as a stroke mimic. Hypoglycemia can be detected by bedside glucose measurement and a history of diabetes mellitus. Hyponatremia can be found through a history of diuretic use, neoplasm, and excessive free water intake. Hypertensive encephalopathy has a gradual onset with global cerebral dysfunction, headache, delirium, hypertension, and cerebral edema. Hyperosmotic coma can present with extremely high glucose levels and a history of diabetes mellitus. Wernicke's encephalopathy usually presents in patients with a history of alcoholism, malnutrition, a triad of ataxia, ophthalmoplegia, and confusion. Labyrinthitis presents with predominantly vestibular symptoms. The patient should have no other focal findings, and it could be confused with cerebellar stroke. Drug toxicity through lithium, phenytoin, or carbamazepine can be detected by particular toxidromes and elevated blood levels. Phenytoin and carbamazepine toxicity may present with ataxia, vertigo, nausea, and abnormal reflexes. With Bell's palsy, the neurologic deficit is confined to an isolated peripheral seventh nerve palsy, and it is often associated with younger age. For Meniere disease, these patients have a history of recurrent episodes dominated by vertigo symptoms, tinnitus, and deafness. For demyelinating disease, especially multiple sclerosis, it has a gradual onset. Patient may have a history of multiple episodes of neurologic findings and multifocal anatomic distributions. And in conversion disorder, there are no cranial nerve findings. There's a non-anatomic distribution of findings, for example, midline sensory loss, and an inconsistent history or examination findings. The NIHSS instructions are as follows. We usually assess the level of consciousness, give questions on levels of consciousness, give commands on the level of consciousness, examine the best gaze, visual fields, facial palsy, motor arm, motor leg, limb ataxia, sensory, best language, dysarthria, and extinction and inattention. When it comes to hemorrhagic stroke syndromes, these include intracerebral hemorrhage, cerebellar hemorrhage, and subarachnoid hemorrhage. Intracerebral hemorrhage may be clinically indistinguishable from ischemic infarction, but the two conditions are distinct clinical entities in terms of management, with higher levels of morbidity and mortality for hemorrhage than for ischemic infarction. Therefore, we perform imaging to differentiate between the two. Headache, nausea, and vomiting often precede the neurologic deficit, and the patient's condition may quickly deteriorate. For cerebellar hemorrhage, it may be clinically indistinguishable from cerebellar infarction. The same clinical presentation and management considerations that were mentioned earlier apply. Subarachnoid hemorrhage is typically characterized by severe occipital or nuchal headache. Patient history includes the recent sudden onset of a maximal intensity headache in many cases. Careful history taking may reveal activities associated with the Valsalva maneuver, such as defecation, sexual activity, weightlifting, or coughing at stroke onset. Mimics can often be distinguished from stroke by careful history taking and physical examination, bedside tests, observation, and appropriate imaging. However, it can be difficult to distinguish conditions with focal transient symptoms such as seizure from transient ischemic attack. The classic mantra, time is brain, explains the current American Heart Association or American Stroke Association stroke guidelines Class 1B recommendation to enact an organized protocol for the emergency evaluation of patients with suspected stroke, in which the goal is to evaluate and decide treatment within 60 minutes of the patient's arrival in the emergency room. Creation of a multidisciplinary stroke team is encouraged, and the culture of the institution should be aligned to encourage rapid diagnosis and treatment of stroke. We train triage personnel to suspect stroke and to quickly activate a stroke critical pathway that includes specific standing orders and procedures. We implement the critical pathway immediately upon that patient's arrival, beginning in the triage area. Notify the emergency physician, the charge nurse, and the CT and laboratory technicians immediately when acute stroke is suspected. Do not delay workup because emergency beds are overcrowded or the emergency physician is currently otherwise engaged, and move the patient to a monitored bed as soon as feasible. Concurrent with focused history taking and physical examination, perform a prioritized group of interventions and diagnostic studies rapidly when acute stroke is suspected. Non-essential testing should not delay performing brain imaging within 25 minutes of the patient's arrival. We obtain emergency non-contrast enhanced CT for suspected acute stroke. Most acute ischemic strokes are not visualized by a non-contrast brain CT in the early hours of the stroke. Therefore, the utility of the first brain CT is primarily to exclude intracranial bleeding, abscess, tumor, and other stroke mimics, as well as to detect current contraindications to thrombolytics, such as evidence of more than one-third middle cerebral artery territory involvement. The CT scan should be reviewed by the most expert interpreter available within 45 minutes of patient arrival, especially if thrombolytic therapy is being considered. The identification of subtle hemorrhage, infarctions involving more than one-third of the middle cerebral artery territory, and early cerebral infarction requires expertise. Telemedicine consultation is an excellent option because reports indicate excellent inter-observer agreement in CT readings between telemedicine stroke neurologists and neuroradiologists. Diffusion-weighted MRI is superior to non-contrast enhanced CT or other types of MRI in the detection of acute infarction. However, the emergency role of MRI for acute stroke is limited because of MRI's uncertain accuracy in detecting acute hemorrhage, lack of rapid availability, patient-specific contraindications, relative inexperience in some practitioners in interpreting MRI scans in acute stroke, and cost-effectiveness. In addition, thrombolytic exclusion and inclusion criteria were originally developed using CT findings, although the use of MRI-based RTPA selection criteria continues to be explored. Post-thrombolysis diffusion-weighted MRI may be useful in differentiating stroke from other diagnoses, such as TIA and stroke mimics, including coronary artery disease in patients who have received RTPA. Despite these caveats, the current AHA-ASA acute ischemic stroke guidelines recommend either non-contrast enhanced CT or MRI as the initial imaging on the acute stroke patient. However, in the vast majority of emergency rooms, a non-contrast enhanced CT is the most readily available imaging study and is the only imaging study necessary prior to administration of antiplatelet. So core interventions for suspected acute stroke include assessment of airway breathing and circulation. Because immediate life threats must be addressed before other interventions are undertaken, we actively manage the airway if necessary. We establish IV access for possible thrombolytic therapy, administer oxygen if hypoxia is present, because it's not indicated in mild to moderate stroke, but should be given if we want to keep oxygen saturation greater than 94%, because poor perfusion also leads to poor outcomes for stroke patients. Cardiac monitoring is done especially in patients with dysrhythmias, especially atrial fibrillation, because these are not infrequent in acute stroke and may predict 3-month mortality. Prophylactic administration of antiarrhythmic agents, however, is not indicated. Bedside glucose determination is done to rapidly rule out hypoglycemia mimicking stroke. We treat hypoglycemia of less than 60 milligrams per deciliter with intravenous dextrose. It is the only laboratory test result required prior to thrombolytic therapy unless the patient is taking or possibly taking oral anticoagulation therapy or heparin, or if there is a suspicion of thrombocytopenia or other bleeding diatheses. Pulse oximetry is done to detect hypoxia. EKG is done for acute coronary syndrome, dysrhythmias, and to determine any EKG changes, elevated troponin T levels, which are frequently associated with acute stroke. EKG abnormalities may also predict 3-month mortality. Non-contrast brain CT or MRI is done to exclude intracerebral hemorrhage, frank hypodensity, especially more than 1/3 of the middle cerebral artery territory, or hyperdensity of ischemia in MRI, abscess, and tumor. CBC, including platelet count, is done to detect polycythemia, thrombocytosis, or thrombocytopenia. Coagulation studies are done to detect pre-existing coagulopathy in hemorrhagic stroke or when thrombolytics are being considered. Electrolyte levels are done to detect electrolyte imbalance stroke mimics, especially with sodium and calcium. Cardiac enzyme levels are used in correlation with the EKG. Nothing per mouth order to protect against aspiration is often done, and strict bed rest in the emergency room protects against falls and seizures in the period immediately after stroke. In patients who can maintain oxygenation, supine position has been recommended possibly to improve cerebral blood flow, but this is controversial. Head of bed elevation to 15 to 30 degrees may be used in patients at risk for hypoxia, airway compromise, aspiration, or suspected increased intracranial pressure. For selected patients, urinalysis or chest radiograph, or both, is done if infection is suspected, in order to detect infectious stroke mimics or stroke-associated infections. Routine chest radiography is not recommended. Pregnancy tests are done if the patient is female of childbearing age because pregnancy influences diagnosis and management considerations. A toxicology screen and/or a blood alcohol level is done if ingestion is suspected because there can be stroke mimics that involve certain toxidromes or alcohol ingestion, such as sympathomimetics like cocaine, methamphetamine, and phencyclidine. And lumbar puncture is also done if infection or subarachnoid hemorrhage is suspected to detect stroke mimics. Thrombolytics should not be given before or after a lumbar puncture because of increased risk of post-lumbar puncture epidural hematoma. When it comes to time recommendations for acute ischemic stroke, beginning evaluation usually should be within 10 minutes from arrival in the emergency room, activation of stroke team within 15 minutes, beginning of head CT in 25 minutes, completing interpretation within 45 minutes, beginning RTPA administration in 1 hour, and admission to stroke unit in 3 hours. For vascular imaging, the current AHA-ASA acute ischemic stroke guidelines state that vascular imaging is strongly recommended only in patients eligible for endovascular therapies, but these studies should not delay RTPA administration. With the advent of endovascular therapies such as intra-arterial thrombolysis and clot retrieval or disruption, identifying the presence of intracranial large vessel stenosis or occlusion is important for therapeutic decisions. CT angiography, digital subtraction angiography, or magnetic resonance angiography can detect intracranial arterial stenosis. Some centers perform CT angiography after non-contrast enhanced CT to identify lesions amenable to endovascular treatment. In acute ischemic stroke, the area of irreversible brain infarct, or the core, is surrounded by ischemic tissue that may potentially be salvageable, regardless of the time of onset of symptoms. The size of this penumbra region cannot be ascertained clinically, so perfusion CT and MRI can be used to measure the size of the penumbra and to guide further therapy for patients who fall outside the time ranges for thrombolysis or where the time of symptom onset is unclear. To date, the impact of perfusion studies on therapy is mixed. For the general treatment of acute ischemic stroke, initial emergency stabilization and interventions are as follows. For general treatment of acute ischemic stroke, not all patients are eligible for systemic RTPA, so it is important to follow general treatment principles on whether or not RTPA is given. Dehydration can contribute to poor stroke outcomes secondary to increased blood viscosity, hypotension, renal impairment, and venous thromboembolism. We correct dehydration with IV isotonic crystalloids. Routine volume expansion and hemodilution do not appear to improve outcomes in stroke patients and should probably not be done, perhaps except in patients with hyperviscous states. For euvolemic patients, we provide maintenance fluids. The 2013 AHA-ASA consensus guidelines recommend oxygen administration to patients in stable condition only as necessary to maintain oxygen saturation at greater than 94% and to maintain normoxia. Routine normobaric oxygen administration does not appear to improve short or long-term outcomes in mild to moderate stroke, and oxygen administration has been associated with increased stroke mortality. Hyperbaric oxygenation is not currently recommended. Fever is associated with an increase in morbidity and mortality in stroke, possibly due to increased metabolic demand and free radical production. We identify the source of fever and treat it with paracetamol. Based on consensus opinion, the current AHA-ASA acute stroke guidelines dichotomize recommendations for hypertensive therapy based on the potential for acute reperfusion intervention. For patients who are not candidates for thrombolytics or reperfusion measures, the guidelines call for permissive hypertension, with no active attempts made to lower blood pressure unless the systolic blood pressure is more than 220 millimeters mercury, or the diastolic blood pressure is greater than 120 millimeters mercury, or the patient has another medical condition that would benefit from lowering blood pressure. If the decision has been made to initiate blood pressure control, a suggested target is a 15% reduction in systolic blood pressure for the first 24 hours. Conversely, blood pressure control is essential prior to, during, and after thrombolytic therapy. A systolic blood pressure of more than 185 millimeters mercury or a diastolic blood pressure of more than 110 millimeters mercury is a contraindication to the use of RTPA because elevated blood pressure is associated with hemorrhagic transformation of ischemic stroke. Therefore, if a patient is a candidate for RTPA, we actively attempt to lower blood pressure to meet these entry parameters. If the target arterial blood pressures for RTPA administration cannot be reached with these measures, then the patient is no longer a candidate for RTPA therapy. The current AHA-ASA guidelines recommend the maintenance of blood glucose from 140 milligrams per deciliter to 180 milligrams per deciliter. We avoid and treat hypoglycemia, defined here as less than 60 milligrams per deciliter. Hyperglycemia is common in acute stroke, and glycemic control has been recommended based on data that associate less favorable outcomes with hyperglycemia. However, glycemic control must avoid hypoglycemia, which in itself can result in brain dysfunction. So when we manage patients who have hypertension before administering recombinant tissue plasminogen activator or RTPA, if the patient is a candidate for RTPA therapy, the target arterial blood pressures are a systolic blood pressure of less than or equal to 185 millimeters mercury and a diastolic blood pressure of less than or equal to 110 millimeters mercury. The drugs include labetalol, 10 to 20 milligrams intravenously over 1 to 2 minutes, which can be repeated once. We use it with caution in patients with severe asthma, severe chronic obstructive pulmonary disease, congestive heart failure, diabetes mellitus, myasthenia gravis, concurrent calcium channel blocker use, and hepatic insufficiency. It may cause dizziness and nausea, and it is pregnancy category C in the first trimester and D in the second and third trimesters. You can also use nicardipine infusion, which is pregnancy category C, 5 milligrams per hour, titrated up by 2.5 milligrams per hour at 15 to 5-minute intervals, with a maximum dose of 15 milligrams per hour. When desired blood pressure is attained, we reduce it to 3 milligrams per hour. We use it with caution in patients with myocardial ischemia, concurrent use of fentanyl because it can cause hypotension, congestive heart failure, hypertrophic cardiomyopathy, portal hypertension, renal insufficiency, hepatic insufficiency, since we may need to adjust the starting dose. It is contraindicated in patients with severe aortic stenosis. It can cause headache, flushing, dizziness, nausea, and reflex tachycardia. For managing hypertension during and after administration of RTPA, from 0 to 2 hours after the start of RTPA infusion, we check blood pressure every 15 minutes. 3 to 8 hours after the start of infusion, every 30 minutes we check blood pressure. And from 9 to 24 hours after the start of RTPA infusion, we check blood pressure every 60 minutes. After the administration of RTPA, if the systolic blood pressure is greater than 180 to 230 millimeters mercury, or the diastolic blood pressure is greater than 105 to 120 millimeters mercury, we give labetalol 10 milligrams intravenously followed by infusion at 2.8 milligrams per minute or nicardipine infusion 5 milligrams per hour, titrated up by 2.5 milligrams per hour at 5 to 15-minute intervals with a maximum dose of 15 milligrams per hour. If blood pressure is not controlled by the above measures, or if diastolic blood pressure is still above 140 millimeters mercury, we consider sodium nitroprusside infusion at 0.5 to 10 microgram per kilogram per minute. We also continuously monitor the arteries, and we use this with caution in patients with hepatic or renal insufficiency. It increases intracranial pressure and is pregnancy category C. The current AHA-ASA guidelines recommend the oral administration of aspirin with an initial dose of 325 milligrams within 24 to 48 hours after stroke onset. However, no antiplatelet agent, including aspirin, should be given within 24 hours of RTPA therapy. In addition, some experts recommend that oral aspirin therapy be deferred until swallowing studies can be done to avoid potential aspiration. The decision to administer RTPA must be made rapidly and accurately. There must be careful identification of the time of symptom onset, defined as the last moment the patient was known to be at baseline. Taking the patient and family chronologically through the events immediately prior to the stroke is particularly helpful in unclear cases. Thrombolytic use in stroke is not recommended when the time of onset cannot be reliably determined. As of this writing, strokes recognized upon awakening, which is up to 29.6% of strokes, should be clocked from the time at which the patient was last known to be without symptoms. Preliminary studies of thrombolysis in these so-called wake-up strokes have been published that suggest that some of these patients might benefit from RTPA, but these results await confirmation by randomized controlled trials. The patient must be evaluated carefully for indications and exclusions for RTPA therapy, and the findings must be documented meticulously, preferably on pre-printed assessment forms. The decision to administer RTPA is made by assessing multiple factors, including the numerical NIHSS score. A score between 4 and 22 is commonly used as one of the criteria for RTPA administration. However, some patients may have a lower NIHSS score, yet have a potentially disabling condition such as aphasia, hemianopia, and gait disturbance. Some studies have also shown poor outcomes for untreated minor strokes. Thus, we interpret an NIHS score in the total context of the individual patient when making treatment decisions. In previous AHA-ASA stroke guidelines, the exclusion criteria hewed very closely to those published by the NINDS and ECASS3 trials. However, in the current recommendations, several of the previous exclusion criteria have been reclassified as relative exclusion criteria on the basis of recent experience. The guidelines urge that the risks versus anticipated benefits of proposed RTPA therapy should be carefully considered if any of the relative contraindications are present prior to administration of the drug. When faced with such patients, obtain emergency consultation with a physician with acute stroke expertise, whether on-site or via telemedicine, because local treatment varies and patient care decisions should be individualized. A bedside blood glucose is required prior to RTPA. However, do not withhold RTPA because of other laboratory results that are pending unless there is reason to suspect pathologic or iatrogenic coagulopathy. We administer RTPA to eligible patients even if endovascular therapies are being considered. The total dose of RTPA is 0.9 mg per kilogram intravenously, with a maximum dose of 90 milligrams. Administer 10% of the dose as a bolus over 1 minute, with the remaining amount infused over 60 minutes. Perform blood pressure and neurologic checks every 15 minutes for 2 hours after starting the infusion. We do not give anticoagulants or antiplatelet agents in the initial 24 hours following treatment because only RTPA trials without early aspirin have shown benefit. Admit patients to a specialized stroke unit if available or an intensive care unit familiar with the use of thrombolytic drugs and neurologic monitoring. If post-RTPA bleeding is suspected, we halt further RTPA administration and perform an emergency CT. Order a CBC with platelet count, coagulation studies, fibrinogen level, N-typing, and cross-match for packed red blood cells, cryoprecipitate, or fresh frozen plasma and platelets. Emergent neurology, neurosurgery, and hematology consultations as needed are appropriate. Be prepared to treat the possible RTPA side effect of angioedema. Other treatment modalities include therapeutic hypothermia, induced hypertension, endovascular therapies, carotid end arterectomy or stenting, and emergency hemicraniectomy for massive infarcts. But benefits are currently unproven. Mild therapeutic hypothermia is associated with improved neurologic outcomes in comatose patients who survive cardiopulmonary arrest. Consequently, there is much interest in the potential benefit of induced hypothermia in acute stroke, but evidence-based data about effectiveness are not available at this time. Animal data in preliminary trials have suggested that implementing drug-induced hypertension in an effort to increase blood flow to the ischemic penumbra may benefit outcomes from acute ischemic stroke. However, there are insufficient data to recommend this modality at this time. There is intense interest in endovascular therapies, primarily intra-arterial thrombolysis and mechanical clot disruption or extraction. Potential advantages of endovascular therapies include an expanded treatment window, a treatment for patients with non-time-based contraindications to IV RTPA, an ability to specifically evaluate the occluded vascular territory, use of lower total doses of thrombolytic drugs, and the possibility of mechanical clot disruption. However, indications, timing, and exclusions have yet to be established. Endovascular treatments are still considered investigational, but they may be considered in patients ineligible for RTPA. The interventional management of stroke 3 trial was designed to compare IV RTPA followed by endovascular treatment, including mechanical clot extraction devices, versus IV RTPA alone, but this study was terminated in 2012 after 656 subjects were enrolled due to lack of power to find statistical significance. The synthesis expansion trial showed no difference between endovascular therapy versus IV RTPA. The mechanical retrieval and recanalization of stroke clots using embolectomy, or the MR rescue trial, showed no benefit to endovascular therapy in patients chosen by presence of ischemic penumbra. In TIA patients with medically treated high-grade internal carotid artery lesions, carotid end arterectomy should be performed promptly because surgical benefit is greatest within 2 weeks of the TIA. The CREST and the International Carotid Stenting Study suggests that carotid stenting is a viable alternative to end arterectomy, especially in patients less than 70 years old, or in patients with higher surgical risks. The evidence-based role of carotid end arterectomy or stenting in acute stroke, on the other hand, is not currently defined. Patients with a massive middle cerebral artery infarct are not candidates for thrombolytic therapy and have an 80% mortality rate. A pooled analysis of data from 3 European trials showed that decompressive hemicraniectomy was associated with better outcomes than medical therapy. However, the head-first pilot trial revealed less mortality at 180 days and 40% in patients with medical treatment than previously reported. In addition, there was no statistical difference between the medically managed patients in this trial and the patients who underwent hemicraniectomy plus medical treatment, and these results may suggest a possible benefit to standardized medical management in these patients. At this time, the decision to perform surgery must be made on an individual basis. Therefore, evidence-based indications for decompressive surgery in acute stroke have not yet been established. There are currently insufficient data to recommend the use of dipyridamole, ticlopidine, or clopidogrel in early acute stroke. Antiplatelet therapy is contraindicated in acute hemorrhagic stroke. The American Heart Association and American Stroke Association 2013 inclusion and exclusion criteria for IV recombinant tissue plasminogen activator in acute ischemic stroke are as follows. Inclusion criteria include measurable diagnosis of acute ischemic stroke through the NIHSS score, and major strokes with an NIHSS score of more than 22 are more likely to have poor outcomes. Onset of symptoms less than 3 hours prior to RTPA administration must be well established and is defined as the time of the witnessed onset of symptoms or the time the patient was last known at baseline, and age greater than or equal to 18 years old. There is no clear upper age limit. Exclusion criteria include significant head trauma or prior stroke in the previous 3 months, symptoms that suggest subarachnoid hemorrhage, arterial puncture at non-compressible sites at less than or equal to 7 days ago, history of previous intracranial hemorrhage, intracranial neoplasm, arteriovenous malformation or aneurysm, seizure with post-ictal residual neurologic impairments thought to be due to the seizure, recent intracranial or infraspinal surgery, Pre-treatment systolic blood pressure of more than 185 milligrams mercury or diastolic blood pressure of more than 110 milligrams mercury despite therapy and active internal bleeding. Thrombocytopenia, defined as a platelet count of less than 100,000 per millimeter cube, is an exclusion criteria, and if the patient has no history of thrombocytopenia, RTPA may be given before this lab result is available, but it should be stopped if the platelet count is thrombocytopenic. Use of heparin within the preceding 48 hours and a prolonged activated partial thromboplastin time, or APTT, greater than upper limit of normal is also an exclusion criteria. So is an international normalized ratio of more than 1.7 or a partial thromboplastin time of more than 15 seconds. Oral anticoagulant use in and of itself is not a contraindication to RTPA. However, derangements in INR and PTT are. If the patient is not taking anticoagulant orally or heparin, RTPA may be given before this lab result is available, but it should be stopped if this lab test comes back elevated above normal limits. That being said, current use of direct thrombin inhibitors or direct factor 10A inhibitors with elevated sensitive laboratory tests are also an exclusion criteria. A blood glucose level of less than 50 milligrams per deciliter and a non-contrast enhanced CT that demonstrates multilobar infarction with a hypodensity of more than 1/3 the cerebral hemisphere. Relative exclusion criteria include only minor or rapidly improving stroke symptoms which clear spontaneously, pregnancy, seizure at onset with post-ictal residual neurologic impairments, major surgery or serious trauma within the preceding 14 days, previous gastrointestinal or urinary tract hemorrhage within the preceding 21 days, previous myocardial infarction within the preceding 3 months. The American Heart Association or American Stroke Association 2013 additional exclusion criteria for IV recombinant tissue plasminogen activator in acute ischemic stroke for patients presenting within 3 to 4.5 hours after onset include a measurable diagnosis of acute ischemic stroke, onset of stroke symptoms 3 to 4.5 hours before initiation of RTPA administration. Additional exclusion criteria include an age of more than 80 years, severe stroke as assessed clinically with an NIHSS score of more than 25 or by appropriate imaging techniques, such as those that involve more than 1/3 of the middle cerebral artery territory, taking an oral anticoagulant regardless of international normalized ratio, and history of previous ischemic stroke and diabetes mellitus. Antiplatelet therapy for stroke recommends the oral administration of aspirin with an initial dose of 325 milligrams within 24 to 48 hours after stroke onset. However, no antiplatelet agent, including aspirin, should be given within 24 hours of RTPA therapy. For transient ischemic attack, it is defined as a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. This tissue-based definition recognizes that although TIA symptoms typically last less than 1 to 2 hours, duration of symptoms is an unreliable discriminator between TIA and infarction. A TIA should be viewed as analogous to unstable angina, that is, an ominous harbinger of a potential future vascular event. In fact, the adjusted odds ratio for stroke less than a month after TIA is 30.4, and the overall 90-day stroke risk after TIA is about 9.2% to 9.5%. View TIAs as ominous signs of cerebral vascular disease indicating a high risk of stroke in the near future. In 2007, the ABCD squared scoring system was intended to replace 2 previous scoring scales, which are the California score and the ABCD score. The ABCD squared score to predict very early stroke risk after transient ischemic attack include A. Age of more than or equal to 60 years old. Blood pressure of more than or equal to 140/90 millimeters mercury. Clinical features, duration, and diabetes. For duration, you are scored 1 if it is between 10 to 59 minutes and 2 if it is greater than or equal to 60 minutes. And for clinical features, you are scored 1 if you have speech impairment without unilateral weakness, and 2 if there's unilateral weakness with or without speech impairment. In summary, although the ABCD squared score has been recommended for use by major guidelines, definitive evidence-based admissions thresholds have yet to be determined. For TIA treatment, we give antiplatelet agents. After TIA, the use of aspirin to prevent vascular events is historically well accepted. Current practice includes dipyridamole plus aspirin, which is reasonable as a first choice, clopidogrel, and aspirin alone. The selection of a particular antiplatelet regimen is a multifactorial decision based on comorbid conditions, bleeding risk, prior drug use, and cause. Adjusted dose oral anticoagulation with warfarin has been the historical therapy of choice for stroke prevention in patients with non-valvular atrial fibrillation and TIA. However, an assessment of warfarin anticoagulation for stroke prevention in the United States demonstrated a dismal rate of optimal anticoagulation control. This has led to multiple randomized controlled trials of novel anticoagulants, which have been shown to have equivalent efficacy but with less risk of intracranial hemorrhage compared to warfarin. The risk of recurrent stroke in the presence of atrial fibrillation without anticoagulation is low, probably less than 5% over the next 48 hours. Moreover, the risk of hemorrhagic transformation of an acute stroke is also greatest in the first 48 hours. Consequently, in the setting of acute atrial fibrillation, anticoagulation therapy typically should not be started in the emergency setting, but should be initiated in the inpatient setting. For special populations such as stroke or TIA with concurrent acute myocardial infarction, the co-occurrence of acute myocardial infarction and acute stroke has implications for acute treatment in the emergency setting. Troponin T elevation in acute stroke is likely to be related to acute myocardial infarction if renal failure and symptomatic heart failure are excluded and is associated with worse clinical outcomes. However, the newer highly sensitive troponin assays do not appear to add additional prognostic information if a fourth-generation troponin assay is normal. Although anticoagulation with heparin is not recommended for the treatment of acute stroke, heparin does reduce extension or reinfarction in the setting of acute myocardial infarction. However, the risk of mortality, the need for revascularization procedures, major or minor bleeding, and recurrent angina appear to be similar with and without heparin. We weigh the risks when requested to initiate heparin therapy by the cardiologist and when advised by the neurologist that heparin may induce hemorrhagic transformation. We consider the patient's baseline cardiac and neurologic status, and the balance often swings to the preservation of cardiac status. For young adults, we exercise particular care when evaluating them. Usually, this is defined as age 15 to 50 with acute stroke. In this group, cervical arterial dissection accounts for 20% of all ischemic strokes and may often be preceded by only minor trauma. The young adult with a cardioembolic event may have mitral valve prolapse, rheumatic heart disease, or paradoxical embolism as the originating cause. Migrainous stroke, which is infarction associated with typical migraine attack, among those with established recurrent migraines, is also a possibility in this age group. Some members of this population are at risk for ischemic stroke from substance abuse. Heroin, cocaine, amphetamines, and other sympathomimetic drugs are often implicated. Human immunodeficiency virus is also a risk factor for stroke in young adults. Women are at an increased risk of ischemic and hemorrhagic stroke during pregnancy and the postpartum period, up to 6 weeks after birth. Potential contributors to this increased risk include the presence of preeclampsia or eclampsia, hypertension, diabetes, sickle cell disease, and drug abuse, as well as the venous stasis, edema, and hypercoagulable state that naturally occur. Following birth, decreases in blood volume, alterations in hormonal status, and the potential for amniotic fluid embolism also contribute. The number of antenatal strokes is approximately 34 for 100,000 deliveries, with an adjusted relative risk in one series of 2.4 compared with non-pregnant females. Interestingly, the overall risk for all types of stroke is far greater during 6 weeks postpartum than during pregnancy itself, with adjusted relative risks versus non-pregnant females of 8.7 and 28.3 for ischemic and hemorrhagic stroke, respectively. Presentation of acute stroke is similar to in non-pregnant patients, although pregnant patients are particularly susceptible to cerebral venous thrombosis, especially during delivery or the postpartum period, and may present primarily with a headache. MRI is generally considered the safest brain imaging study, but the benefits of an emergent non-contrast enhanced CT clearly outweigh the risks to the fetus in this setting if MRI is not immediately available. A head CT exposes the fetus to less than 1 rad. RTPA does not cross the placenta, and there are reports of successful IV RTPA use for stroke in pregnant patients. Emergency treatment of stroke in pregnant women should ideally involve early consultation with obstetricians, stroke neurologists, and neonatologists as appropriate. For the sake of consolidation, stroke is generally defined as any disease process that interrupts blood flow to the brain. Injury is related to the loss of oxygen and glucose substrates necessary for high-energy phosphate production and the presence of mediators of secondary cellular injury. Subsequent factors such as edema and mass effect may exacerbate the initial result. The major types of stroke include ischemia and hemorrhage, with ischemic strokes accounting for 87% of all strokes and hemorrhagic accounting for 10% of all strokes. Ischemic strokes may be further subdivided into thrombotic, embolic, and hypoperfusion related. Hemorrhagic strokes are subdivided into intracerebral and non-traumatic subarachnoid hemorrhage. The arterial supply of the brain includes the anterior parietal artery, the Rolandic artery, the pre-Rolandic artery, lateral orbitofrontal artery, superior division of the middle cerebral artery, the middle cerebral artery, the temporopolar artery, the inferior division of the middle cerebral artery, the anterior temporal artery. The visual radiation is also something that can be implicated in stroke, the post-temporal artery, the angular artery, and the post-parietal artery. The anterior circulation of the brain is divided into ophthalmic, anterior cerebral, and middle cerebral arteries, and the posterior or vertebral system is divided into the vertebral, posterior inferior cerebellar, basilar, posterior cerebellar, and medial temporal lobe arteries. Traditional symptoms of stroke include sudden numbness or weakness of the face, arm, or leg, especially unilateral, sudden altered mental status, sudden aphasia, sudden memory deficit or spatial orientation or perception difficulties, sudden visual deficit or diplopia, sudden dizziness, gait disturbance, or ataxia, sudden severe headache with no known cause, and non-traditional symptoms include loss of consciousness or syncope, generalized weakness, shortness of breath, sudden pain in the face, chest, arms, or legs, seizure, falls or accidents, sudden hiccups, sudden nausea, sudden fatigue, sudden palpitations, and alterations in mental status. Nihss instructions include level of consciousness, best gaze, visual, facial palsy, motor arm, motor leg, limb ataxia, sensory, best language, dysarthria, and extinction and inattention. Usually, RTPA administration should be given 1 hour from arrival at the emergency room and an admission to stroke unit at 3 hours from arrival at the emergency room. Management of hypertension before administration of recombinant tissue plasminogen activator can be done with the drugs labetalol or nicardipine. And management of hypertension during and after administration of recombinant tissue plasminogen activator requires frequent monitoring of blood pressure and the use of labetalol or nicardipine or sodium nitroprusside. Aspirin is a mainstay of stroke treatment. We usually give it at a dose of 325 milligrams within 24 to 48 hours after stroke onset. However, no antiplatelet agent should be given within 24 hours of RTPA therapy, and this includes aspirin. The total dose of RTPA is 0.9 milligram per kilogram intravenously with a maximum dose of 90 milligrams, and we administer 10% of the dose as a bolus over 1 minute with the remaining amount infused over 60 minutes. As usual, our source is Tintinalli's Emergency Medicine. Thank you very much.